Hello everyone, welcome to Miss Doc T. This is Dr. Farheen, General Medicine resident, and today let's discuss hemochromatosis. By definition, hemochromatosis is a group of genetic disorders predisposing to iron overload resulting in tissue damage and organ failure. So remember that hemochromatosis is the name given to genetic disorders with iron overload and organ failure, and so it is also known as hereditary hemochromatosis. Now this needs to be differentiated from secondary iron overload. Here there is an iron overload due to non-genetic or acquired causes like excess dietary iron, thalassemias, blood transfusions, hemolytic anemias, and chronic liver disease because the iron storage capacity of the liver is lost and iron is released outside, leading to secondary iron overload. This includes hepatitis, alcoholic liver disease, non-alcoholic steatohepatitis, and also in porphyria cutanea tarda. So, secondary iron overload is due to some non-genetic cause, whereas hemochromatosis is the word used for genetic causes of iron overload. The clinical manifestations of both these conditions is the same, but the treatment of secondary iron overload is to treat the underlying cause. Now we'll look at the genetic basis of hemochromatosis. HFE gene is located on the short arm of chromosome 6, that is on 6p, and this HFE gene encodes a HFE protein which has 343 amino acids. This HFE protein acts through beta 2 microglobulin and through the transferrin receptor 1, and it causes two main functions. Firstly, the HFE protein inhibits the divalent metal transporter 1 in the duodenum, and so it inhibits iron absorption from diet. And secondly, the HFE protein complexes with the transferrin receptor 1 on the liver, and it inhibits the uptake of iron, and so it decreases iron storage in liver. The action of HFE protein on duodenum is mostly through beta 2 microglobulin, and the action of HFE protein on liver is through the transferrin receptor. So a normal HFE protein decreases duodenal absorption of iron and decreases liver uptake of iron, and so it regulates body iron content. Now if there is a mutant HFE gene, the most common mutation being replacement of cysteine by tyrosine at amino acid position 282, which is denoted as C282Y, and the second common mutation being replacement of histidine with aspartic acid at the amino acid position 63. So mutation in HFE gene produces a mutant HFE protein, and this cannot inhibit the divalent metal transporter 1 in the duodenum, leading to excess absorption of iron from the duodenum, and it also cannot complex with the transferrin receptor on the liver, and so the liver is free to uptake excess of iron, thereby leading to iron overload and hemochromatosis. Along with HFE gene, hepcidin also plays an important role in hemochromatosis. Please watch the video on iron metabolism for a better understanding of hepcidin. We'll just look at hepcidin in brief. So ferroportin is the channel through which iron is absorbed from the gut, and also iron is released from the splenic macrophages and liver into the circulation through the same channel, ferroportin. This ferroportin is inhibited by hepcidin so that excess iron doesn't enter the body, and so it regulates the body iron levels. When there is an abnormal hepcidin, ferroportin is not inhibited and the excess iron reaches the body, leading to hemochromatosis. Also, the hepcidin levels are indirectly regulated by HFE protein. So this HFE protein and hepcidin play an important role in pathogenesis of hemochromatosis. Now the genes involved in hemochromatosis are divided into HFE genes and non-HFE genes. The HFE gene is located on the short arm of 6th chromosome, and it encodes the HFE protein, which we have already seen. And the non-HFE genes that can cause hemochromatosis include genes encoding hepcidin, hemojuvelin, transferrin receptor 1, and ferroportin. These are the genes involved in hemochromatosis, and it progresses in 4 stages. The first stage is there is genetic predisposition, so the mutant genes may be present but there are no clinical manifestations. The second stage is there is iron overload, usually seen in biopsy or in lab reports, but without any clinical symptoms. The third stage is there is iron overload with symptoms, and the fourth stage is development of organ damage. So these are the 4 stages in the progression of hemochromatosis. Now, the excess iron deposits in various organs, producing the clinical manifestations of this condition. Liver is the most commonly involved organ, and hepatomegaly is seen in more than 95% of patients with hemochromatosis, and it may progress to cirrhosis and hepatocellular carcinoma. Excess iron depositing in pancreas can damage the islet cells and cause diabetes. Excess iron depositing in the skin can produce a metallic hue known as bronzing. And all these features put together is known as bronze diabetes and is typically seen in hemochromatosis. Then, deposition of iron in the heart leads to congestive heart failure or arrhythmias. Excess iron can also cause arthropathy. Second and third metacarpophalangeal joints are the first to be involved, and then it progresses to involve other small and large joints of the body. Then, deposition of iron in the hypothalamo-pituitary axis leads to hypogonadotropic hypogonadism. Arthropathy and hypogonadotropic hypogonadism cannot be reversed even with treatment, and these are the clinical features of hemochromatosis. Now, coming to the diagnosis. So, in the pathogenesis itself, there is an increased iron absorption from the duodenum. So, the circulating iron is increased, that is, the transference saturation is increased, and also because the uptake is increased in liver, the storage form of iron is increased, that is, the serum ferritin is also increased. And so, in hemochromatosis, the transference saturation as well as serum ferritin will be increased. And whenever these two are seen to be elevated, go for genotyping of HFE gene. So, a combination of transference saturation and serum ferritin levels is the first step in the diagnosis of hemochromatosis and is also used for screening of hemochromatosis. If both of them are increased, then the second step is to do genotyping of HFE to decide the treatment. Now, coming to treatment of hemochromatosis. It should be initiated as early as possible to prevent progression of the patient to cirrhosis and hepatocellular carcinoma. Treatment focuses on removing the excess of iron from the body. The first method is phlebotomy. Here, approximately 500 ml of blood, that is almost 250 milligrams of iron, is removed once or twice a week. This is done till the serum ferritin comes to less than 100 micrograms per liter, which takes about 1 to 2 years, and thereafter phlebotomy is done every 3 months to maintain serum ferritin to less than 100 micrograms per liter. The second method is to use iron chelating agents, and this is used when phlebotomy cannot be done, like in patients with anemia or hypoproteinemia. The chelating agents are of two types: parenteral agents, which include deferoxamine, which can be given as a subcutaneous infusion or intramuscular or an intravenous route, and also oral iron chelators, which include deferriprone and deferazirox. So this is about the treatment of iron overload. This is all about hemochromatosis. So that's all for today. Thanks for watching. Hope you liked it. Let's meet again with another new topic. Till then, just take care, be happy, and stay safe.